Okay, so continuing with Unit 2, Evidence-Based Public Health, we're now to Part 3 of our PERI approach recommendations. So we're going to be talking about risk versus benefit, strength of evidence, and our rating system for recommendations. So recommendations is what would work, and this has to be based on evidence. Again, not just like Beverly's idea, hey, I know, let's try such and such. We want to actually have data to support that we think that our interventions are going to be helpful. And so that data could be case control studies, it could be cohort studies, and hopefully even randomized controlled trials, because these are interventions, right? These are potential treatments. So usually we can have that higher quality data for these because there aren't the same ethical concerns. Because we're trying to help people, not look at what causes disease. But anytime we're going to intervene, we need to acknowledge that sometimes the things that we do can cause harm, even when we mean well. We need to make sure they're safe. So in medicine, Hippocrates of the Hippocratic Oath, ancient Greek physician, said primum non nocere, which means first do no harm. So make sure whatever you do that you're not going to make things worse. Or someone, Martha Moody, more recently, sometimes the cure is worse than the disease. And if you've ever known anyone who's had chemotherapy for cancer, you can understand why that sometimes is true. So we want to make sure that we're not making people worse by accident. So let's take an example using COVID vaccines. Why not? So this is some early data looking at efficacy protecting against infection and hospitalization or death. So protection against infection is no longer quite as robust as it once was. It's down around 30% probably now. Depends on how recently you got your vaccine and your booster. But the effectiveness or efficacy against hospitalization or death is actually still quite robust. It's still around 75%, so I've circled that one. So that's a significant reduction in your risk for severe illness or death from COVID-19, and that still persists for vaccinated folks. But there are risks with the COVID vaccines, just like there are risks for any vaccine. Every vaccine has risks. Every vaccine can potentially kill you. We are activating your immune system after all, and sometimes things get screwy. So let's take a look at one of the risks that occurred with one of the brands of COVID vaccine. So this is something called thrombotic thrombocytopenic syndrome. I'm not going to quiz you on that. You just need to know it caused some weird blood clotting problems. And it was seen with the Janssen vaccine, which was an adenovirus vaccine. So this is the data on, and I have my glasses this time, how often we actually saw those cases. So they've broken it down into female-bodied and male-bodied people and age group. And what you can see is that there were 13 cases in female-bodied people under age 50, which gave a rate, an incidence rate of 7 per million. So they had to do per million instead of per 100,000 because it's so rare, right? So out of 1 million doses given to people in this age group, 7 of them developed this complication. Now, this complication is potentially devastating. So some of these people died. A lot of these people were permanently disabled. They got blood clots in the brain that caused inability to function. I actually have a friend who got this and is still disabled. She didn't die. She's still alive, but she's still disabled from this side effect from this vaccine. Now, you'll notice, too, that in the female-bodied people who were over age 50, it was much less common, and that it didn't happen in any of the male-bodied people. So there are some baseline differences in risks for blood clotting problems in male versus female-bodied people, primarily due to the estrogen levels in their bloodstreams. And so we see this risk in some groups of people and not others. So this is a problem, right? This vaccine is causing harm. And so the question then becomes, how does that risk stack up against the benefit? So what they did was they took a look at, okay, for different age groups and different body types, what are the risks versus the benefits? So up here we have per million vaccine doses administered. So remember, in that young women, we saw 7 cases. So you would cause 7 cases of this potentially fatal and potentially disabling condition, but look, you'd prevent 6 deaths, 56 ICU hospitalizations, and 297 overall hospitalizations. In the over age 50, look at how many more deaths you prevented, right? Those were people at higher risk of death to start. And then in the males, right, again, young people don't die from COVID as often as older people. And they're thinking, maybe we'd see 1 case, maybe, in male-bodied people who are less than age 50. So taking a look at this, they said clearly for everyone over age 50 and for even male-bodied people under age 50, the benefits far exceed the risks of this vaccine. But for this one age group, I mean, yes, the benefits still, if you stack it all up, because not all of those people that get this weird blood clotting thing actually died from it, right? So if you stack just purely numbers wise, the benefit still exceeds the risk, but it's like, it's not huge, right? It doesn't hugely outweigh. And so once this was found, and it took a while, it didn't show up in those initial randomized controlled trials of the vaccine. Why? Because those were 35,000 people. This is 7 in a million. So you're not going to start seeing it until you've got hundreds of thousands of people getting vaccinated. So it takes a while to see these really rare events. They never show up. They almost never show up in the initial studies because they're so rare. So once this was found, then there was an interim recommendation saying, you know what, you probably shouldn't use this vaccine in female-bodied people under age 50. The benefit still does exceed the risk, but the ratio, there's other options, use other vaccines for them instead. Because interestingly, this did not happen with the other versions of the vaccine that were out there and are still out there. And in fact, this vaccine, the Janssen vaccine, is no longer used in the United States. So the other vaccines do not have this side effect, and so once these vaccines were expired, they didn't file to have them reapproved. We don't have this one anymore. Right? There are safer alternatives available. So you might say, all right, Dr. Hall, but I also heard about like some kind of heart inflammation thing that can happen from the COVID vaccine. Yes, let's talk about it. So that's called myocarditis. Myocarditis or pericarditis, that's inflammation of the heart or the membrane surrounding the heart. And we saw, again, not in the initial studies, but later, once the population started getting vaccinated, we had hundreds of thousands of people getting vaccinated. We saw that there were some cases of myocarditis, especially in male-bodied people. So what I'm showing you right now is, and this one is also per million, I'm pretty sure. Oh, it doesn't say. Pretty sure this one is per million also. The number of cases of myocarditis that would occur in male-bodied people, because this one interestingly only happened in male-bodied people by age. So it was most common in young male-bodied people. So we can see a total of 128 cases of this. 110 of them were put in the hospital for at least a day or two, most of them just 1 or 2 days, and no ICU and no deaths. Right? So that's good, right? It didn't kill anybody. But you don't want to have your heart inflamed. And in older age groups, the risk was even less. Okay? So even lower. So the risk was highest in these younger male-bodied folks. But let's look at the benefits. Right? So dying from COVID-19 is not common in young males, but it does happen, right? And vaccination would prevent 51 deaths for every 110 cases of hospitalization for myocarditis that you cause, right? And then look at all the hospitalizations of COVID that you would prevent. So benefit still far outweighs the risk. And if we look at this older group, that's not even close, right? Benefits greatly outweigh the risks. So for this reason, they still recommend that you can absolutely use the COVID vaccines in young men. The benefits still far outweigh the risks. And in fact, COVID infection itself can cause myocarditis. Let me show you. And in fact, COVID infection is more likely to cause myocarditis than most of the vaccines. So this is events per 1 million. So these three here are the Pfizer vaccine, first dose, second dose, and booster. So it's about 3 per million will get myocarditis from the Pfizer vaccine. This one is Moderna here. These three are Moderna. And only the second dose of Moderna, for some weird reason, showed this safety signal. So about 35 per million, or slightly less than that. But look, this is actual COVID infection here in unvaccinated people. So if you're going to get COVID, you're going to get you're just as likely to get the myocarditis as if you got the Moderna vaccine, right? And then if you got COVID but you'd previously been vaccinated, it's protective against myocarditis. So that's nice. So as someone who had a teenage son, once I saw this data and I knew about this, did I still get him vaccinated against COVID? Yes. I absolutely did. Did I care whether it was Pfizer or Moderna? Not really, actually. I mean, I was kind of glad that it was Pfizer because I was like, well, might as well minimize the risk as much as you can. But if the only option that we had was Moderna, I still would have gone for it, right? Because it still would have prevented all of those excess hospitalizations and deaths. Right? So myocarditis might not be very different, but it would still save all those other things. And I say this as someone whose neighbor, actually my neighbor's son, who was a cross-country runner, got myocarditis from his COVID infection. And he had been a state qualifier for cross-country. He couldn't run for over a year. He had to be on heart medicines. It was awful, right? It was terrible. So myocarditis is no joke, but risk versus benefit, absolutely still beneficial to get the vaccine. And I'm just reminding you, he didn't get it from the vaccine, he got it from COVID. All right. And in fact, if you compare COVID infection versus the Pfizer vaccine, you're more than seven times as likely. So the relative risk is greater than 7 to get it from a COVID infection as you are from the vaccine. So when we're looking at making recommendations for potential interventions, anything has risk, right? I ate peanut butter this morning. You can die from peanut butter, right? You might be allergic to it. You might choke on it. You can die from eating peanut butter. But I ate peanut butter this morning. I made a calculated decision. The benefit of the nutrition and the pleasure was far outweighing the risk. So our key always is to make sure that the risk is far outweighed by potential benefit. So that's what we call net benefit. We want the net benefit to be large. So when we're looking at assessing interventions, seeing what is going to be the most helpful, we're looking at how helpful it will be, what the magnitude of the impact is, or the net benefit. Again, keeping in mind potential risks and minimizing those as much as possible. And then looking at the quality of the evidence that we have. Like, how good is this data? Do we have 20 randomized controlled trials showing us that this is relatively safe and highly effective? Or do we have like a couple of cohort studies that suggest it might work? So we want to really be clear and upfront when we're making these decisions or recommendations about like how confident are we that this is going to be helpful. So we have a rating system. The rating system's used in public health versus medicine sometimes are slightly different. I'll show you an example of that in a minute, but they follow the same general pattern. So again, we're looking at the quality of the evidence or the data that we have and the size of the net benefit. So here we see a substantial net benefit, right? So something that looks like it's very, very helpful. And if the evidence is good, excuse me, then we're going to give it an A rating, right? That's awesome. Slam dunk, right? We have lots of really good evidence. This is really, really helpful. Yes, we should definitely do it. Now, if the benefit is just moderate, then we're going to say B, even if the data is really good. Or if the benefit is moderate or the net benefit is substantial, but the data is only fair, like it's still like, I'm not totally sure, then we're going to say B. If we have really crappy evidence, even if it shows potential substantial benefit, we're going to actually give it an I. And in the beginning, that's what ivermectin was. We're going to come back to ivermectin in a minute. Okay. If the net benefit is small, then we're going to say, C, which means you could consider doing it. If it doesn't help at all, or it makes you worse, then we're going to say D. So think of D for don't. Just don't do that for your patients. A is you should do this for everybody. B is you probably should do this. C is like, well, you could consider it. D is don't. And I is I don't know. We have no clue. We don't have good data to inform us. So let's take a look at how some of these ratings play out. So this happens to be treatment guidelines from the NIH, the National Institutes of Health, for treatment of adults who aren't in the hospital, so who aren't super sick with COVID-19. And this first box is actually from a couple of years ago, because I want to show you that it changes. But what you're going to see here is that they've given you ratings. Right? So everybody should be offered symptom management. Yeah, you can have Tylenol if you have a fever or something, right? And then notice that 3 there. So that 3 means that's just expert opinion. All right. But then we can look at for patients who are at risk of progressing to severe. So people who have underlying risk factors for progressing to severe. A rating for Paxlovid, 2A. So 2A means that there's some randomized trials or subgroup analyses of randomized trials. So that's pretty good data. Now you could use remdesivir, but look, that's a B 2A, right? So moderate, right? Not as strong a recommendation. And then these guys down here, it's a C. It's like, well, maybe they're helpful. We're not totally sure yet. So what's interesting is if you look at the current guidelines that are posted today, these look really the same. Nothing has changed substantially except that this one, subsequent data showed that it doesn't work. So it's not on the recommendations anymore, right? So we just took it off. It's a D now. It doesn't work. So that one got taken off. Okay, I promised you we would talk about ivermectin. Why isn't ivermectin on here? Oh, and it's interesting to see that, Paxlovid is the recommendation for people who have risk factors. So you might remember that President Biden in summer 2024 had COVID. Actually, it was after he got COVID that he announced that he wasn't going to run for re-election. And he was treated with Paxlovid because based on his age, he's at high risk. So that is an A recommendation. You should definitely do it. The benefits far outweigh the risk, and we have pretty good data. All right. So ivermectin. So the interesting thing about ivermectin is there was a lot of hope that it might be useful. So there was some biologic plausibility. Remember, that was a supporting evidence criteria that we talked about earlier. And that is that in vitro, so in a petri dish, ivermectin will inhibit the ability of the SARS virus to replicate itself, or basically grow. Viruses don't really grow, but so it can fight SARS-CoV-2, the COVID virus, in cells in a petri dish. Now the problem with that is that the doses that were required about 100 times the doses that we ever actually use in people. But anyway, they were like, well, it's worth a shot, right? We didn't have anything in the beginning. So there was an early cohort study, there were a couple of them actually, that showed that the patients who received ivermectin, because they're just, throwing things at the wall, seeing what would stick, right? Seeing what might work. The patients who got ivermectin did do better. They were less likely to die. They were less likely to end up on a ventilator. They got out of the hospital sooner. But these weren't randomized controlled trials. And so when you looked at the patients who received ivermectin versus the ones who didn't, a lot of times they were a lot younger. A lot of times they were less likely to be smokers. They were less likely to have underlying lung disease or heart disease or high blood pressure or other things that we know also increase your risk of severe illness or death from COVID-19. Sorry that the light is weird. But this was promising, right? So we're kind of going through those levels of evidence, those 3 requirements. So they said, okay, let's do some randomized controlled trials. And so there have been more than a dozen really well done, good sized randomized controlled trials of ivermectin now, and it doesn't seem to work. So this is from that same NIH website, and you can see now the recommendation is they recommend against ivermectin. It's an A recommendation, and that's also because in these randomized controlled trials, people had a lot of side effects from ivermectin. Ivermectin itself can cause problems. It can cause heart rhythm problems. So they found no net benefit, and therefore they recommend against the use. So if you want to read more, there's some links there, so you can kind of, satisfy your curiosity about ivermectin. I'm happy to talk to you more about it if you like. Everybody was really hopeful. It'd be great if a cheap, easily available drug was highly effective, but our best data shows that it just doesn't work. And it could be harmful, right? There's potential side effects, so we don't recommend it. So overall, when we're talking about recommendations, then we want to look at the magnitude of the net benefit, how helpful it is, right? What's the risk versus benefit? We don't want to have a lot of risks. We want to have a lot of benefits. And then what's the quality of the evidence? Do we have a lot of randomized controlled trials, or do we just have a few observational studies? Because the goal is we want to know how can we do the most good with the most certainty and assuredness that it actually is going to work. And then once we know that, once we come up with our recommendations, the question becomes, how do we make those happen? And that's implementation, which is next. See you then.